This is the case of complex stenting and angioplasty of an internal carotid artery stenosis following endarterectomy. The case is one of a 69-year-old woman who presented with frequent spells of dizziness and syncope. Neurologically, she was non-focal. However, she was noted to have elevated Dopplers on serial ultrasound examination. On the right, her velocities were 550 over 130, indicating a very high-grade stenosis. We first obtained access using a VTEC catheter, over which we advanced a Cook shuttle into the common carotid artery on the right. Ideal placement of the shuttle catheter is within a couple of centimeters of the carotid bifurcation. Before proceeding with the procedure, we first obtain cervical and cranial views to have a baseline and for measurement. Using these measurements, we're able to select balloons and stents that will appropriately size for the anatomy. We then bring in a hydrophilic microwire and microcatheter combination in order to cross the extraordinarily narrow stenosis. After several attempts, we're able to cross the lesion, at which point we advance our microcatheter across and into a distal portion of the carotid artery. Given the extraordinarily stenotic lesion, we must first perform a preplasty in order to subsequently advance our stent. We do this using an exchange wire over which we pass a balloon into the region of the stenosis and just very briefly inflate the balloon in order to give us enough space in order to pass a filter. We withdraw the balloon and subsequently deploy a distal filter device. With the filter in place, we can be more aggressive with our maneuvers and open up the stenosis more fully. We next use our balloon to again open up the stenosis with a more aggressive pre-angioplasty to allow for the stent to be able to pass through the region. The stent is then passed through the area of the stenosis and is deployed in the usual fashion. We deploy in 3 phases, with first unsheathing of the stent, followed by extrusion by pushing the stent wire. We then complete the process of deploying the stent by unsheathing the final segment of the stent. Once this has been completed, we pass an IVUS microcatheter into the distal portion and then withdraw very slowly at approximately 1 millimeter per second. Here we inspect for a cheese grating of the lesion or any intrastent thrombus. Here we see none. At this point, we obtain a follow-up angiogram demonstrating good revascularization through the previously stenotic lesion. Intracranial views show no evidence of distal emboli.